Hello and welcome to the March 2019 session of the Patient Safety Webinar Series. Thank you everyone for joining us. We're so happy to bring you another session of this series co-hosted by the UNC HSC SaferCare Texas as well as the NNLM South Central region. Our speaker today is Lillee Gelinas. She is Senior Fellow and Nurse Executive with SaferCare Texas based at the University of North Texas Health Science Center in Fort Worth. The mission of SaferCare Texas is to challenge traditional thinking to eliminate preventable harm locally, regionally, and nationally. Lillee is an accomplished healthcare leader with extensive experience in hospitals and health system operations, including national, international, for-profit, and not-for-profit systems. Her expertise reflects an exemplary career spanning a range of nursing leadership and executive roles, from staff nurse to national system chief nursing officer, including military service in the U.S. Navy Nurse Corps. She is a fellow in the American Academy of Nursing, a recognition attained by less than 1% of the 4 million registered nurses in the United States. She is also a certified professional in patient safety and serves on numerous federal, national, and regional committees and boards, including the CMS Nursing Steering Committee, the National Quality Forum Patient Safety Steering Committee, and is co-chair of the Joint Commission Nursing Advisory Council. In 2006, she was appointed to the Editorial Advisory Board for American Nurse Today, the official journal of the American Nurses Association, and has served as editor-in-chief since June 2014. Lillee earned her bachelor's degree in nursing from the University of Louisiana at Lafayette and a master's degree in nursing with honors from the University of Pennsylvania, where she also studied at the Wharton School of Business. She is currently a student at Duke University pursuing a Doctor of Nursing practice degree. Please join me in welcoming Lillee Gelinas.
Thank you so much, and hello everyone. It's good to be with you today to discuss such an important topic. The title of today's presentation is Burnout Among Healthcare Professionals, the Unrecognized Safety Imperative. But before we begin, let's reflect on today is March 7th. It's the 66th day of the year, actually the 77th day of winter, and there's only 13 days until spring. But what's important about March 7th? Well, in 1778, Captain James Cook first sighted the Oregon coast. Alexander Graham Bell patented the telephone on this day in 1876. Today is also National Cereal Day, but it was interesting to me that today is also observed as National Be Heard Day, because when we talk about the topic of burnout, we talk about healthcare professionals that may be in emotional pain. We need to hear them, and we'll be talking more about that today. So happy March 7th. Our learning objectives for today are to discuss recent research linking burnout to poor personal and organizational performance, identify promising approaches and current strategies to address fatigue and burnout, understand how to recognize risks in coworkers and team members, and describe resources available for personal and organizational well-being. But first, let's talk about you. And what I'd like for you to do in the chat box is let me know, what do you want to know about this topic? Why is this topic so important to you? So to get the juices flowing, let's have an interactive survey, so to speak, and just think about where you are in terms of how sleepy are you right now as you listen to my voice and you participate in this webinar. And to think about quantitatively evaluating how sleepy you are, there is the Epworth Sleepiness Scale on your screen. It's a fatigue and sleepiness self-assessment. Now, it is unscientific. It is not one that you would want to use for academic research, but you can use it to ascertain what are your chances of dozing right now. How likely are you to doze off or fall asleep in the following situations, in contrast to just being tired? So this scale refers to the usual way of your life in recent times. So think about what is your chance of dozing on a scale from 0, meaning no chance of dozing, to 3, high chance of dozing, in these situations: sitting and reading, watching TV, sitting inactive in a public place like you're in a theater or in a meeting, as a passenger in a car for an hour without a break, lying down to rest in the afternoon when circumstances permit, sitting and talking to someone, sitting quietly after a lunch without alcohol, and in a car while stopped for a few minutes in traffic. So I'm curious what your scores might be. In order to assess what your normal daytime sleepiness level might be, if you scored between 1 and 6, congratulations, you're getting enough sleep. If you scored between 7 and 8, you're average. And if you scored 9 and up, you need to seek the advice of a sleep specialist without delay. Now that's the high-level summary, but in general, these scores can be interpreted with more granularity. What's interesting to me is I've conducted this very unscientific survey with staff and with students. And I can't tell you how many times using this low-tech assessment, the score is 8 and up. And as you see, that would fall into the higher normal daytime sleepiness level. That can be an issue for you. So I'm looking at the chat boxes, Sarah, and I'm seeing a lot of 0s and 1s. So our audience is not very sleepy, which is a good sign. But why is a self-assessment such as this important to get our brain juices flowing and get us thinking about what is it that we need to know about the link between sleepiness and burnout? Sustained sleepiness over time can be a wake-up call for you and your organization. When you think about current or impending mental and or physical exhaustion, these scales are frequently helpful in helping us understand that burnout and sleep disorders have relevant bidirectional effects, especially with medical students in the early phase of medical school, which is where the majority of the formal academic research has been done. Emotional exhaustion and daytime sleepiness can show important mutual influences and, again, should be a wake-up call. And daytime sleepiness is linked with cynicism and academic performance in students. It's also linked to cynicism and organizational performance in healthcare organizations. At the end of this presentation, you'll see a list of references, and the ones that I refer to on the slides are listed there in APA format. So what about some of the resources that I want you to know about before we really dive into this topic? These are good resources, and I want to make sure that the links are going to work for you. The first one on the left is part of the National Academy of Medicine's very specific website dealing with this issue. It's called the Clinician Wellbeing website. There are 95 different references that are listed in the paper that you see here on your screen. Burnout Among Healthcare Professionals, a call to explore and address this under-recognized threat to safe, high-quality health care. I'll discuss the Clinician Wellbeing website in just a moment, but wanted you to know about this excellent discussion paper, and it clearly articulates the links between burnout and patient safety that we should all be concerned with. So if the National Academy's paper is the state of the state and why we should care, on the right to your screen are resources and solutions that American Nurse Today has given us permission to distribute to you. The Wellness 101 series has a number of articles about how to stay well, how to deal with stress, how to deal with burnout, emotional exhaustion, how to stay healthy. And there's also a great article called Tips for Achieving Healthy Sleep. May seem like no-brainer to you, but we really do need to think about how do we take care of our personal approach to sleep so that our organizations are not affected by our sleepiness. So let's dive in. Let's get started. What is burnout? The definition on your screen was developed by Maslow in the early 80s. The Maslow Burnout Inventory is considered the gold standard for assessing burnout. It was first published in 1981, refined in 1982, and it's been the primary basis ever since for the most burnout research. It's a 22-question measure of 3 dimensions of burnout: emotional exhaustion, depersonalization, and low personal accomplishment. So this definition is from Dr. Maslow's book, and it is still used today. Burnout is a syndrome of emotional exhaustion, depersonalization, such as cynicism, and reduced personal achievement that can occur among individuals who do people work of some sort. So let's make sure we don't confuse terminology. The words burnout, compassion fatigue, and depression are often used interchangeably, but these are actually 3 different conditions. Burnout is a state of emotional, physical, and mental exhaustion that stems from our work. It can lead to depression, which affects all areas of our lives, resulting in changes in sleep patterns, appetite, mood, and at its most severe, hopelessness and thoughts of suicide. It's related to the nature of the work. So studies show that as workload increases, so does burnout and job dissatisfaction. In nursing, there are several studies that show that 18% of new nurses leave the profession within 1 year and 60% plan to leave within 8 years. And the leading reason that they want to leave is overwork. Compassion fatigue is a state where healthcare workers want to connect with patients and families on an emotional level, but over time they may lose that capacity due to compassion fatigue. It's not an intentional switch. It's a form of burnout that causes people to disengage from patients, families, peers. It's a vicious cycle. It's chronic, unacknowledged stress causes it. And some of the signs and symptoms include avoiding meaningful interactions with colleagues, families, and patients, feelings of failure, poor performance and errors at work, and a desire to quit jobs or the profession. Depression is a psychiatric illness with clear symptoms that are outlined in the Diagnostic Statistical Manual of Mental Disorders, which those of us in the healthcare professions refer to as DSM-5. Burnout is focused on the work experience, while depression is felt in all areas of one's life. Compassion fatigue is a type of burnout that impacts the emotional connection clinicians have with their patients and causes them to disengage. Depersonalization is an attempt to put distance between oneself and service recipients by actively ignoring the very qualities that make them unique, make them engage people, and in the healthcare professions, why we went into healthcare to begin with. I do want to note that moral distress, signs and symptoms, and coping mechanisms are a related topic, but because of time, they're not covered in this webinar. I do want to note, though, that compromised clinical judgment does cause frustration, hardship, and moral distress, and a big factor in burnout is feeling compelled to act unethically. So dealing with ethical dilemmas and the related moral distress can lead to the emotional exhaustion associated with burnout, a good topic for another webinar. So with terminology set, let's talk about our first objective and the recent research that links burnout to poor personal and organizational performance. An important concept is that burnout is primarily a system issue. Some of the contributing factors are workplace inefficiencies, all of the burden of accreditation and certification requirements, the actual practice and learning environment itself and inefficiencies there, organizational and practice demands, policies and procedures, for instance, workplace chaos, time pressures, reporting requirements, and overall workload. In your reference list, you're going to note a February 2019 paper that was just published in the journal PT in Motion, and it noted the causes of burnout for physical therapists over a multiple-year span of research. And the top three were untenable productivity requirements, documentation demands, and school debt, causing a debt-to-income burden hard to overcome. And it's noted that these three issues are common across many healthcare professions. So, burned out from overwork? Yes. And some of the indicators that we need to be aware of are when we see a rise in overtime, we need to understand that our workers that are working overtime are actually threatening a patient-safe environment. The Bureau of Labor Statistics maps average weekly hours worked for all healthcare and hospitals in particular. And in one of the latest versions of the BLS.gov statistics is just how much rising hospital work reflects rising overtime. So you should be very, very concerned about that, since we know there's a direct correlation between working overtime, causing fatigue and being tired, being emotionally exhausted, and then burned out. In 2011, the Joint Commission, which tracks adverse events across healthcare, was so concerned about what was happening in this whole burnout, fatigue, and error space. They put out a Sentinel Event Alert. It's Sentinel Event Alert issue 48. And it was updated in June 20th, 2018, and you can see the hyperlink if you would like to get a copy. It's free of charge. But there's some important quotes in that particular work. One of them is, an overwhelming number of studies keep saying the same thing. Once you pass a certain point, the risk of mistakes increases significantly. Dr. Ann Rogers at Emory cites that, and she says, we have been slow to accept that we have physical limits, and biologically we are not built to do the things we're trying to do. The Joint Commission Sentinel Event Alert is still current. It still relates this direct link between exhaustion, fatigue, and patient safety, and I would recommend that you read it in order to get a better understanding of these direct links. So let's recognize the signs of burnout. If you regularly wonder if you're making a difference, or if you dread going to work, guess what? You might be burned out. And just as we were talking earlier about the importance of using the same terminology, depression and burnout are frequently used interchangeably, but they're not. So let's consider the differences. To the left of your slide, you'll see the signs of depression, and they're not always visible. These are some of the traits to look for, and remember, these apply to one's whole life. Sleep disturbances, changes in appetite, feeling hopeless, irritability, feeling less engaged in activities you used to enjoy, feeling isolated, not finding joy in life, and bringing less energy to work. Now, contrast those with the signs of burnout, where you feel depressed or exhausted during a shift or work day, but you feel contented outside of work. You're contented when you go home. You're working solely for the paycheck. You don't get the fulfillment you originally got from your job. You feel irritable or short-tempered at work. You no longer enjoy getting to know students, team members, or patients, or whoever is in your work environment, and you don't make an effort to build a rapport with others. So when you consider the signs of burnout, these are some of the effects. Burnout has wide-ranging consequences for clinicians, patients, and the entire healthcare system, and they can be severe. Some of those effects include medical errors, patient mortality, which was illustrated in a study published in Frontiers of Psychology, as well as other publications. High turnover. As a matter of fact, turnover is so high associated with burnout that it's equivalent to eliminating 7 medical school graduating classes in 1 year. Another effect is the loss of attention and focus, leading to diminished cognitive function, which puts patient at risk for increased probability of safety lapses. The bottom line is, burnout harms. Some of the other effects of burnout in numerical terms Again, these are from the National Academies of Medicine website. Medical trainees experience higher rates of depression and burnout than those of age-similar individuals pursuing different careers. And you can see the difference between depression and burnout rates. Burnout is nearly 2 times as prevalent among U.S. physicians than among workers in other fields. The effects of burnout are also felt by nurses. 24% of ICU nurses tested positive for symptoms of post-traumatic stress disorder. 23 to 31% of nurses have emotional exhaustion. Those are primary care nurses, not just acute care nurses. Physician rates of depression remain alarmingly high, 39%. But this statistic really got my attention. 400 physicians die by suicide each year, a rate more than 2 times that of the normal population. And that's from a study recently done in 2015. Look at this. 43% of inpatient nurses have a high degree of emotional exhaustion. And we're allowing it to happen and continue. And then we wonder why nursing turnover is so high. So let's emphasize once again the relationship between burnout and patient safety. Burnout is a stronger predictor of patient safety than demographic or organizational characteristics. There's a positive relationship between emotional exhaustion and mortality ratios as an objective patient safety indicator. In addition, workload and trainee status can predict patient safety. Tell me the number of hours you work. Tell me the number of hours you are awake studying as a student, and we can predict how unsafe the environment is for patients. So when we think about the systemness of burnout and the consequences of burnout, think about employees, employers, colleagues, and patients. From an employee standpoint, there is the personal health impact, family difficulties at home, supervisors see deteriorating work performance, and a low sense of personal accomplishment. Employers see higher absenteeism, lower presenteeism. I love that. You're just not present. You're a warm body at work. Higher turnover, reduced productivity, and overall impact on clinical and financial performance. But colleagues see it too. There's acquired burnout. Don't let that happen to you, and don't let it happen in your team. But if one person is exhibiting signs, it can have an impact on the entire team and cause poor team performance. And then there's resentment and unhealthy team dynamics because other members of the team are picking up for the frailties of the employee that's exhibiting burnout. But for patients, this is where we should be concerned too. There's less than optimal quality of care, higher rate of medical errors, and lower patient satisfaction with the system. So now let's talk about some promising approaches and current strategies to address fatigue and burnout. And let's look to NASA for some of those lessons. Strategies for organizations derived from studies by NASA have found that success can be maximized by trying different combinations of countermeasures to find what works best for individuals. So within an organization, having a system approach is important because what works for one employee might not work for another. So the organization needs to assess the organization-wide fatigue-related risks and understand that handoffs are high-risk actions and must assure safe practices are in place and consistently followed. Having an education plan about sleep and the effects of fatigue on safety consistently executed across the system. Many organizations have education about sleep annually as part of their mandatory education plan. Creating and implementing a fatigue management plan for the system is important, and within that plan for individuals, emphasizing the need to engage in conversations and move and practice, I love this term, strategic caffeine consumption. In other words, don't use caffeine when you're already alert or to avoid caffeine near bedtime, but too much caffeine can actually keep you up and disrupt sleep. And NASA is a real proponent of short naps, less than 45 minutes, to reduce sleepiness overall. And of course, developing and maintaining a safety culture, which without it, a safety management plan and a fatigue management plan are just not going to work. NASA says the #1 strategy to avoid sleepiness, the only way to counteract it is to sleep. So to avoid burnout, some personal actions, I love word art, and you have one to the right of your screen around purpose. But working with purpose, why do you come to work? It's not just to get a paycheck, is it? You have some purpose. You're making some contribution. You're fulfilling the organizational mission. You're making a difference. Also, performing a job analysis. This is really important so that you clarify what's expected of you and you're not guessing what you should be doing day by day. It's important to identify what your role is and what you should be doing in your role, and learning if excessive workload exists and bringing that to the attention of those above you. Another one is giving to others, helping in small ways. Acts of kindness are absolutely re-energizing, and that's why volunteering really has benefit. Taking control of your day, taking control of your time, learning prioritization, not just doing a to-do list, which is important, but a not-to-do list. This is what I'm not going to do today. And creating daily, weekly, monthly, and yearly personal goals. And if they have to do with the organizational goal achievement, make sure you're showing those with your supervisor. Exercising, getting a good night's sleep. But this is one that I've learned that you might want to do yourself, and that is keeping a stress diary. So in a stress diary, you're noting date and time, a recent stressful event you experienced, like the boss canceled a meeting, or the office printer broke down, or there were train delays and you were going to be late to home again, or another project landed on your desk when you were already busy. And you write down how happy you feel on a scale from 0 to 10, what your mood was, the fundamental cause of the event, physical symptoms that you experienced during the event, and how well you think you handled it. A daily stress diary can really give you insights in how you're managing stress and how you might have to be perhaps doing things differently. So how do we recognize risks in our coworkers and team members? Because that's where we are every day. We work with others. Recognizing burnout in others have several signs that are not only reported in the literature, but I think you would see that they absolutely are intuitive. What happens if someone on your team looks or feels tired all the time? They disappear. I had a staff nurse one time where for an hour they disappeared and they were going to sleep somewhere. And the team began to notice that and said that team productivity was taking a beating because of it. But it was the team that noticed that and alerted me. Withdrawing from social activity, odd behavior, are they moody or irritable, or even if they're quiet or regressed? Change in physical appearance. They have a lack of motivation. You have to tell them what to do all the time. They're not self-starters. They appear to be having cognitive problems. They're not thinking clearly. Maybe they're making mistakes in jobs or in reports or what they're trying to achieve. Overall, decreased job performance. So what do you do? Where do you get help? Well, like with many other issues, if you see something, say something. Alerting your supervisor, leadership awareness is so very important. Now, this is easier if your organization has a fatigue management plan in place, because it's expected that we're alerting each other when you're concerned about a team member. And most organizations have employee assistance programs that if you can identify a team member that appear to be having signs of mental or physical exhaustion or burnout, you can refer them to the EAP program, working with your human resource professionals about how to do that. The second is making a difference together as a team and being concerted about it. I really like the idea of discussion groups in organizations and purposeful activities to resist the forces of burnout, knowing that they're going to happen. There are 3 clear phases of burnout. There's your energy level over time. The green zone is the okay zone, where you're functioning appropriately. The yellow zone is when you're getting into the burnout zone, where you begin to notice some of those signs and symptoms I noted earlier. The danger zone is the red zone, and that's the one you want to avoid, but you need to be able to recognize it in yourself. The tools where you're able to assess your own level of burnout, I know we did a fun one right in the beginning of this webinar, but there are ways for you to understand that you might be getting into the danger zone. Now, a way to do this is actually the assessing the burnout phase of the team and the individuals in the team, and that way it is not as threatening. But just working harder sometimes doesn't work. It's a good sign of burnout and your productivity has dropped. The third strategy is having a prevention strategy, which is a plan for yourself, your department, and your organization. It takes all 3 to keep the organization healthy. Ask yourself, does your organization have a burnout prevention work group? What a great idea. I see a lot of committees and groups across organizations, but this is one of the emerging ones that seem to work, put into place by leadership, because you know it's going to happen, you know it is happening, and so it's a great prevention strategy that's just beginning to take root. And the other one that was interesting in the literature was the bad outcome peer mentor. In other words, these are mentors who are trained and respond to bad outcomes and are the ones that are best educated and have good psychology backgrounds to be able to deal with someone and diffuse a situation before it becomes overbearing. So those are some of the promising resources, and I hope you got a couple of good ideas from those. So what about other resources that are available for your own personal and organizational well-being? Here is that website I alluded to in the beginning of the webinar that is in place by the National Academy of Medicine. On it is the Clinician Wellbeing Knowledge Hub, and if you click on Knowledge Hub, you'll see the Sharing Knowledge tab, and in it is the Communications Toolkit that is filled with a number of resources you can download free of charge depending on what your particular issue might be. This is the website for the Clinician Wellbeing website, the Sharing Knowledge to Combat Clinician Workout, but it really is comprehensive to the resources for all professions. On the right side of your screen, you can see you can hyperlink from the Clinician Wellbeing website to the American Nurses Association Healthy Nurse, Healthy Nation website, or you can hyperlink to the American Medical Association's website called Steps Forward, which is a series of learning modules designed to help practitioners achieve the quadruple aim and be healthy while doing so. The National Academies also developed this Clinician Wellbeing and Resilience conceptual model. It depicts the factors associated with well-being and resilience and applies these factors across all healthcare professions, all specialties, all settings, and all career stages. It emphasizes the link between clinician well-being and outcomes, which is so important for us to understand that when we're tired, when we're fatigued, when we reach a level of burnout, we really are impacting patients and the entire healthcare system in a negative way. We use this model to understand well-being, and I want to underscore this is not a diagnostic or medical assessment tool. This is to understand all the dimensions of well-being, and you can use this when you write your fatigue management plan for your organization. The yellow areas of the model, of the conceptual model, I'll tell you what, I was telling Sarah, this was really hard to absorb, but there's a lot in it. And every single bullet point on this slide, the National Academies of Medicine has an article or a resource related to it, or an issue that you perhaps need to take a deeper dive into. And then the internal factors that need to be considered, those personal factors, things like, do your employees have access to a personal mentor? And what are the financial stressors or economic stressors that are in their life? I talked about earlier the article that just came out in February talking about student debt when they first start working and how that is such a burden that leads to burnout. And skills and abilities are internal factors that we really always need to stay cognitive of. I especially think it's important around resilient skills and practices and teamwork skills and practices. These aren't innate. They really do need to be learned. So how about a preventing burnout personal checklist? As you're listening to this webinar today, I want you to think about a to-do list that's your personal anti-burnout checklist. Are you attending stress management workshops or courses or dialoguing with your colleagues around, wow, what do we need to be doing in our team, in our organization, in order to positively affect the healthcare system overall related to burnout? Mindful communication programs, mindfulness, presenteeismness, there's such a word. Daily self-care, exercising, healthy eating, and sleep. What choices are you making? Because frequently choices are leading us down the path to burnout without recognizing that. In many of the healthcare professions, we go into healthcare because we want to help people. And we keep taking on, and our shoulders get heavier and heavier. But we haven't learned to say no, or we haven't learned to prioritize, or we haven't learned to share as a team what the projects are or what the care goal is, and we're taking it all on ourselves. So understanding what some of our choices may be may help us get through these phases where we don't end up being clinically burned out. Promoting wellness in those with whom you work. Recently, I had a great boss, and you know what? We did our one-on-ones walking around the hospital. We didn't sit in anyone's office, and we had a clipboard, and we took our notes on the clipboard or our iPad, but we actually walked. And it was also managing by walking around, because while we did that, we would see things in the external environment we had to call facilities to fix, or we had a chance to interact with some employees. It really was a great way to get out of the office, to have meaningful and purposeful one-on-ones, but promoting wellness in each other. Peer group discussions are so very important about this topic, and having safe space to do that. And knowing your danger zones. Like I said, are you in the A-OK zone? Are you in the yellow zone, or are you in the danger zone? So some of the additional no-cost resources as you build your burnout library and as you build your organizational fatigue management plan. The New England Journal of Medicine has a website called Catalyst, and they frequently publish credible research projects. One of their collections of original content on physician burnout is the one published in November 2018. You see it on the left on your screen. It's called Physician Burnout, the Root of the Problem and the Path to Solutions. I like these publications that have, yes, the root of the problem, and yes, remind us how we got here, but give us some solutions and show us the path forward. The National Academy's publication in 2004 called Keeping Patients Safe, Transforming the Work Environment of Nurses has been reaffirmed in literature and in research time and time again, and guess what? We know what to do, we just don't do it in a consistent way across the 5,000+ hospitals in the United States. And the National Patient Safety Foundation's Lucian Leap Institute published a great publication called Through the Eyes of the Workforce, Creating Joy, Meaning, and Safer Healthcare, which also gives many ideas and solutions about how we need to be helping our workforce get healthier so that our healthcare system gets healthier. So here's a final thought, and then I'll open it up for your questions. If all the knowledge and advice about how to beat burnout could be summed up in one word, that word would be balance. Balance between giving and getting, balance between stress and calm, balance between work and home. Now, this is Dr. Maslow again, cited in numerous publications, but it really is a way to get your arms around, it is a balancing act. I'm very grateful to have a wonderful husband, a wonderful son, a great home life. Yes, I can go home stressed, but I do sleep at night, so maybe I'm not in the burnout zone because I've got someone at home that helps me. Ask you, who's helping you? Where is your support coming from? Is it your team? Is it at home? It's really important to call that out. So back to the beginning. If you joined us late, you might not have seen the sleepiness survey that we took, but I think it'd be fun for you to take it. Do it in your next team meeting. See what kind of results you get across your team. You see my email address there, and of course Sarah's. And we want to be able to engage you and understand what you're seeing as well as we bring the webinar to a close. Now in the chat box, I also see colleague Bob Dent. And Bob, welcome to the webinar. I'm so glad you're there. I consider you one of the best in nursing and nursing leadership. And you say we've seen a rise in nurse suicide too. That is absolutely correct. Unfortunately here locally we've seen it, and we need to understand how can we go upstream and do a better job assessing our workforce, our student populations, our faculty, our physicians. How do we begin to understand across each other who's in the danger zone? And that's what we're not doing. Everyone gets in that danger zone without others knowing it. And unfortunately, we see the rise in nurse suicide. Another question, will we receive a copy of this recording? Sarah, can you speak to that?
Absolutely. I was just typing up a response. It'll probably be faster for me to just say, yes, we will be posting this recording on our YouTube channel. Debbie, our support person, can put a link to our patient safety webinar page on our website. The link to our YouTube will be available there. We also will be planning our next patient safety webinar soon, and once we have the details about that and we send out an email, we'll also make sure to include the link to this recording as well. But you can absolutely check on our website. The link will be available within the next week or so for this recording.
Sarah, we have a great question about the research on the role of the nurse manager or frontline manager. There's quite a bit of research, and we need to put that together and post it as a part of the resources for this website. You know, I think there is the nurse manager burnout level in itself because of the role. The frontline manager, whether it's nurse manager, pharmacy manager, whatever that frontline manager role is, really being very, very susceptible to burnout because of the amount of responsibility, accountability, and authority vested in that particular role. So it's important that we're assessing on a regular basis. As a matter of fact, one of the emerging ideas I saw is when you're having either your one-on-one or even your annual performance review with your supervisor, the two of you going through some type of fatigue assessment or readiness assessment, readiness for duty assessment, as we would say in the Navy, having an explicit conversation about what your level might be, what might be causing stress, and a nurse manager having a comfort level for being able to assess fatigue and burnout across all staff members. Unfortunately, there are a lot of nurse managers that can have 60, 100, 150 FTEs reporting to them, don't see a lot of their staff on a regular basis, and might not be in a position to do those types of assessments. It's really important to talk about what that's going to mean for especially a manager that has a very, very broad scope of responsibility. How do you get your arms around understanding the fatigue level of the staff?
So I'll also, I have the link there. If you'll use the second link, the one that has Patient Safety Series, that's where we'll post the link to this. I have another question here for you, Lillee. Especially for maybe some of the non-healthcare professionals, maybe some of the librarians who are on this call, do you have any suggestions about how we can get involved, especially for fighting burnout in healthcare professionals early on? I know many of us are working on medical school campuses and that kind of thing. So do you have any suggestions for how to get involved with that?
You know, I think as you and I were preparing for this this webinar, and I was lamenting to you about the amount of non-credible, non-academic resource that's out there, it scares me a little bit that that's out there and may actually be misinforming either organizations or academic medical centers like ours. Being proactive, as a matter of fact, on the American Nurse Today Editorial Advisory Board, we have a librarian. And I know you're not surprised, but we need to embed librarians in committees, in curriculum committees, in organizational committees, not just asking a librarian when we need help, but they need to be at the table so they know what the topics are that we're discussing and what might be able that they can help. I don't think there are enough librarians embedded in the day-to-day operations of organizations where their talent could be utilized. It may very well be that librarians need to offer free either face-to-face sessions or webinars within their organization just to let them know what they might be able to help. So if you're listening today and you're a librarian, putting out a note to the CEO or the VP of HR or the dean of the medical school or the pharmacy school saying, hey, I was on a webinar today. I became very, very aware of some issues I think we need to get our arms around. Number one, do we have a fatigue management plan in this organization? If not, I can do some research for you and find out ones that may align with this organization. Or what can I do to help you build some of these resources into safety curriculum so that students become aware very early on. For chief nursing officers, patient safety officers, and others, fatigue management needs to be built into orientation programs and into yearly educational programs so that we begin to build resilience, not just in a person, but in an organization.
I'm sure many of the librarians on the call will be happy to hear about your comments about how critical we are to helping people find that authoritative information. I do also have another privately sent question here. Can you speaking about curriculum, could you talk a little bit more about what our campus has in place for burnout, and maybe as an example of what people can be looking at going forward?
Our business unit, SaferCare Texas, works closely with all of the schools around patient safety curriculum. We haven't been here very long, as you know, and we are embedding it in what we do in that total systemness, safety as a system issue. I don't want to go down the rabbit trail related to that, but we can do better. All of us can do better. This is one topic that will never get old. The research is updated constantly, and I think that for you, Sarah, because you're so talented in this area, if we were to be able to put a credible literature search on our website so that the faculty could access it when they have a question. But I do think it's baby steps. It's one step at a time. The good news is that we're here. The good news is that all of the SaferCare Texas staff are engaged across all the clinical and academic entities here. Not everyone has the benefit of that. It's exciting to see, and it's exciting to see the vision of this organization around SaferCare. Because at the end of the day, that's what we're all about, eliminating preventable harm. To eliminate preventable harm includes having non-sleepy students, staff, physicians, and employees.
Absolutely. All right, well, it looks like we don't have any other new questions. Again, we do have both Lillee and my email address and our phone numbers there on the screen if anyone does have any questions. I do want to finish this out, stop the recording, and then go to our final housekeeping items. But first, a huge thank you. Thank you so much for this fabulous presentation, Lillee. Really appreciate you being here today with us.
Thank you.
All right, so at this point I will go ahead and stop the recording and then we'll move into our final items.